We have one more session and we're moving on logically to the topic, and we've already discussed these words, haven't we? The words have come up: biomarkers, diagnostics and prevention. And the term liquid biopsy. And we have with us the founder and the president of the European Liquid Biopsy Society, Professor Dr. Klaus Pontel, Institute of Tumor Biology at the University Hospital Hamburg, Eppendorf. Welcome. Thank you very much.
Excellent. Thank you very much. There's a famous saying, don't get your case before court before lunch, right? But I hope that is not true for our talks here at the last session before lunch. It's really my pleasure to talk today about the use of liquid biopsy for early diagnosis and detection of MRD in pancreatic cancer. And it would be nice if the slides would move forward. I'm pressing so we can see. Okay, now it comes. Well, what's liquid biopsy? I think that we have actually coined this term together with Katrina Lix-Panabier from Montpellier 15 years ago as the analysis of circulating tumor cells in the blood, but very frequently it has been adapted to other circulating tumor-derived products, in particular the circulating DNA fragments, but also RNAs or extracellular vesicles. And we have included also circulating host cells into that definition. What is the rationale? Why do we need it? Tissue biopsies are the gold standards, no doubt about it, but they are invasive procedures and some locations are difficult to access. In contrast, getting a blood sample is very easy and minimal invasive. Moreover, I think that the blood is also a pool of tumor cell and products that is released from different metastatic or primary lesions, and I think that it may get more comprehensive information than the biopsy of a single metastasis. And most importantly, you can take sequential blood samples every day, every week, every month to get information on the real-time monitoring of tumor evolution and therapy responses. So it maybe opens a new vision for a more comprehensive and real-time tumor information by the analysis of blood samples, and it can be also applied on other body fluids, but I will focus on blood today. So what are the origins of the tumor cell products and tumor cells in the blood? In the primary setting, I think the primary tumor is the key source, but also when you have a more advanced disease, the lymph node metastasis will contribute, and in advanced disease, of course, the distant metastases are the sources of tumor cell products in the blood. What can we detect in the blood? We have a cellular fraction, the fluidic fraction. In the cellular fraction, we can find circulating tumor cells as single cells or cell clusters. We also have circulating host cells, such as immune cells, endothelial cells, or cancer-associated fibroblasts. In the plasma fraction, the circulating DNA fragments have become a major target of liquid biopsy analysis, with some entry already in clinical practice. But there are also other molecules or other analytes, such as extracellular vesicles, proteins, RNAs, or even tumor-educated platelets. We have actually implemented and established a large European network, the European Liquid Biopsy Society, which was really a follow-up initiative based on a 5 years EU IMI grant. And why did we do that? Because there is a big gap between thousands of publications on biomarkers, but maybe not even 10 new ones implemented into the clinic each year. So I think to close that gap, we have really established and continued this network here. We have working groups on dissemination and education. We have a working group on clinical questions that can be solved by liquid biopsy. A working group on the technologies with, I think, subgroups on the different analytes that interacts closely with the questions that are addressed by the clinical working group. Then we have a regulatory working group dealing with IVDR regulations, but also in particular with reimbursement, which of course is a big bottleneck for implementing new biomarkers. And we have 2 new working groups, the data computation group, because of course AI is becoming increasingly important, and we have also a patient advocacy group. So if you're interested, we are not a closed group. We are very happy to welcome new members. And it's very simple. Just write me a mail. Very, very little bureaucracy. We hate bureaucracy, by the way. So this was our general assembly that we had last year in November. And if you are interested to know more about our network here, we have just published the report from this general assembly at the beginning of this year. So I actually have the pleasure to coordinate 2 large European projects using liquid biopsy, and both involve pancreatic cancer. The first one is on early detection of cancer. And I don't have to motivate you at all why we need early detection of pancreatic cancer. The previous talks have said that already in a fantastic way. So here we have actually a 5-year project. We are probably in the middle of this project right now. 18 institutions from 8 countries supported by the European Union Horizon project. And I'm happy to have Matthias Löhr from Karolinska as a co-coordinator. What are actually our assets? Why did we get the grant, or why can we try to actually get such a blood test for early detection of pancreatic cancer? Why do we have a small chance? It's a very ambitious project, of course. We have actually biobanks from patients collected over 10 and more years. These were patients with early stage pancreatic cancer, which is quite rare, as we know, but also patients that are at high risk to develop pancreatic cancer. So we can decide between patients that have high risk and develop pancreatic cancer and those that did not. Then we have experts from the liquid biopsy areas, including the circulating DNA, but also the tumor cells, proteins, metabolites, and the exosomes. And we have a very, very motivated and a great expertise in data computation with Nuria Malatz from the CNIO, who will hopefully help us to develop a classifier to detect this deadly disease as early as possible. I should also mention we have a working package on health economy evaluation with an expert from Hamburg and Karolinska, and we have a very active patient organization which is partnering here. Just to show you one set of data, I think that we have, for example, looked here at proteins in my lab. We have identified one protein, and I think the title is missing. It's called CCN1 or CR61. It's a stress-related protein. We have previously published that it could distinguish between breast cancer already in very early stages and healthy individuals. We also have some data on lung cancer and asbestos-related diseases. And here, the ROC curve on the right side shows you our newest unpublished data with pancreatic cancer, combining this protein with the CA99. And I think it's at least promising and good step. And we hope if we add more proteins or other analytes that we can even improve this ROC curve. So what are the benefits? I think scientifically we get some hopefully ideas about the biology of pancreatic cancer, not only develop a marker. We also, I think, will hopefully have a marker at the end of these 5 years and the blood tests that we could actually then try to implement. I think that it's very important for society to reduce the mortality and get a better life quality of the PDAC patients. And I think we have also included small, medium enterprises here. The second EU group is on early detection of minimal residual disease. Here it is, I think, very important to note that the liquid biopsy opens now a new opportunity. I don't know. Okay, now it's coming. A new opportunity to detect a residual disease earlier than imaging. We know now that with the liquid biopsy, we are able to see whether after the initial therapy, whether there is cancer left in the body of the patient or not. And if this is increasing really, we have a chance by early detection of this relapse to act earlier and maybe have still a chance to cure patients as opposed to waiting until full metastatic relapse occurred that we can detect by imaging. So that is the idea here. And the question is really, what is the best technology to detect and stratify MRD positive patients, and which therapy can eradicate or control MRD. And this is probably opening a new avenue for so-called post-adjuvant clinical trials, and that's probably why many of also the pharma companies are involved in our grant application here, because they also see that this new diagnostic invention opens really a new type of clinical trials, not only treating patients at the beginning of the diagnosis or in the adjuvant phasing or at the metastatic, but also in between. So what are the challenges for the circulating cell-free DNA in the blood that we tackle in this consortium? We have two types of DNA tests. One is tumor-informed, so we sequence the tumor tissue, we develop patient-specific probes, and the advantage here is that we have a very high sensitivity possible. The disadvantage is we need high-quality tumor tissue, and it was mentioned already today that sometimes with the biopsies that can be a challenge. The second technology is really non-tumor informed, which means we use actually panels which encompass the known genetic aberrations. Here you don't need tumor tissue, but usually you have a lower sensitivity. What are the biological challenges? And I think that's very important to keep in mind. If we become too sensitive, we may hit a background of genetic aberrations in normal cells, and this is really bad news before lunch. Everybody who has a certain age, it has also cancer-associated mutations in leukocytes, but probably also in other cells. So bad news, really. Don't get old. No. Get older and don't think about that during lunch. So we also know that, on the other hand, some tumor lesions are non-shedders, so we may get false negatives, and there is already an ongoing program finding out what is the reason for that, the biological reason. And of course, we need to detect very low concentrations, probably going down to 1 parts per million for early stage disease detection or MRD detection. So this is actually the scheme of our ongoing consortium. It's an IHI consortium of the EU, so it's a public-private partnership between academic institution and industry. We have the following objective. We want to create reference standards and benchmark ctDNA assays. We want to do then a clinical validation in colorectal, pancreatic, and lung cancer, and then integrate MRD as a decision tool to guide treatment selection. These are the clinical studies. These are prospective observational trials. Patients receive standard of care therapy in colorectal, pancreatic, and lung cancer. Then at the end, we will compare it to the gold standard, which is then, I think the field is developing rapidly, technology, so we want to see what is at that time's gold standard, and then design a small prospective randomized interventional trial. Here you see what we are doing really in this consortium. In these 3 cancer types, we take blood samples before, but most importantly after adjuvant therapy, and also during the follow-up. And we want to see which technology can actually detect this relapse as early as possible. And we will do a side-by-side comparison of 5 or 6 different technologies, because we can collect here 50 ml or more blood, which was really fantastic that our ethics committees allowed us to do that. So just to say that biology of relapse is, of course, not only depending on the tumor load, also the tumor cells can have very different qualities. You can have active proliferating micrometastasis contributing to a blood signal. You may have hibernating dormant tumor cells that may not contribute. And of course, there are only maybe a few cells that contribute to as metastasis initiator cells. So maybe in the future, we will not only look at the tumor burden, but also at the tumor quality. So in conclusion, I think that liquid biopsy is being used in our lab for cancer detection and early diagnosis. We also use it for preoperative risk assessment and prognosis. I didn't talk about that today, but here we can also get an idea who can have a de-escalation of therapy or an escalation of therapy. De-escalation probably plays a higher role in tumors with a better prognosis. Then MRD detection and prediction of recurrence. I talked about that today. Then we can use the information from the liquid biopsy for treatment selection because we can look at molecular alterations. We can assess the treatment response, identify resistant mechanisms by sequentially looking at blood samples. And last but not least, learn something about metastasis development in the cancer patients. Thank you very much.
Professor Pantel, thank you very much. A lot to think about during lunch. I'm thinking more about the Mediterranean, the Greek diet. Perhaps not the US diet. Let's turn our attention to the US. Dr. Anirban Mitra, Scientific Director of the Pancreatic Cancer Research Center at UT MD Anderson Cancer Center, Houston. Welcome.
Thank you. Thank you, Seamus, for the introduction. Dr. Efra, thank you for hosting us. And Dr. Ivana, thank you so much for the invitation, Juan. I really, what an honor. So I think Yoshi set the stage this morning with a wonderful talk about surveillance and earlier detection of pancreas cancer. I don't have a purple ribbon, but I do have a purple tie. Hopefully that's a good enough substitute. And Klaus, you're such a hard act to follow, but I'll do my best. And you actually shared some of the themes that I'll briefly touch on in my talk. That's the building we are in. So much of my talk, actually all of my talk, will be focused on pancreas cancer because it's a lethal disease. It's with common late-stage presentation, as you heard, about 80–85% present with late stage. There's no established early detection test. Klaus is working on it, and hopefully Pancade and others will get that going. But it is a prototype for what I call enrichment, and I put that in red because it's a very important part of how we can implement feasible population-level early detection strategies. And you heard a little bit about that in what happens in Korea, but how do we work around a system like the United States where you can't just go around doing endoscopies on everyone? So enrichment is going to have to be a must in a healthcare system like ours. Okay, so this is what I as a pathologist, I look at. This is pancreas cancer, ductal adenocarcinoma. I only show this to emphasize that even though 95% of cancers in the pancreas are ductal adenocarcinomas, which is what you see here and which is what I will talk about, there are other variants like neuroendocrine tumors and other rarer subtypes. We'll not talk about that. So I'm using the term pancreas cancer and adenocarcinoma interchangeably for this talk. So improvements in survival for this disease, and Yoshi talked about it, but the reality check in those numbers is that has really mostly happened in the context of localized disease, not in the metastatic patients who are the vast majority of individuals who come to the clinic. So these are the numbers from this wonderful publication that the ACS releases every year in the called Cancer Statistics. And you can see here that, unfortunately, while the 5-year survival for localized disease is approaching 50% now, which is remarkable, the distant metastatic disease is still only 3%. And unfortunately, those patients and the regional disease, which are all basically patients you can't undergo, on whom you cannot perform surgical resection of the tumor, those tend to be the majority of individuals. And in fact, at MD Anderson, when we look at the last 25-year experience of patients who had localized disease, received neoadjuvant therapy, got surgery, got adjuvant therapy, the survival of those patients have really improved dramatically, as you can see with that red curve on the right-hand side. But again, these are the individuals who are contributing to that improvement in survival that we talk about in pancreas cancer. So one of the things we do know about this disease, and this is again not for folks like Steve and John who have done this for a living for many years, but for the rest of you in the audience, one of the things we know about this disease by looking at retrospective abdominal scans in patients who developed pancreas cancer but had other scans done for something unrelated or some vague abdominal symptom. This is actually a study from the Mayo Clinic. When radiologists went back and looked at those scans with the hindsight of 2020, what they found was that this sort of window of resectability that subset of disease where you can really have long-term survival and potentially cures is really a very small window. It's a matter of months by which time a cancer that is resectable today becomes unresectable tomorrow. And we also saw that in this data looking at pre-diagnostic samples, and Dr. Robbins, in her talk, she talked about one of these cohorts, the PLCO cohort, where the L is actually for lung cancer, but as you can imagine, in a population of thousands of patients, there will also be individuals who develop pancreatic cancer, and so we have pre-diagnostic samples from them, which means you have samples before they were diagnosed with pancreas cancer, so you can see when is my signal showing up in these individuals. What we found was when we looked at CA19-9, there's this sharp upturn that happens in the last 1 year or so before diagnosis. Again, reiterating what I said in my last slide, that this disease really accelerates in the last 1 year before clinical onset. But there is this window where you can potentially diagnose this disease and get it at the resectable stage. So in the US, we have a body, just like you have in Europe, that comes up with screening guidelines. It's called the USPSTF, Preventive Services Task Force. And what they give as a grade for pancreas cancer screening in the general population is a failing grade of D, which means do not screen the general population. And again, this is in sharp contrast to what we just heard in the context of gastric cancer screening. So basically, the PSTF says, no, don't even think about screening the general population because there's actual potential for doing harm if you screen these individuals. And why is that? And the simple answer for that is the incidence rate, the population prevalence of pancreatic cancer is about 15 per 100,000 in the US. And so even if you had the best biomarker, and I know that Klaus is working on that, but at this point it doesn't exist. But let's just say you have a hypothetical biomarker that has 100% sensitivity, which means it doesn't miss any patient with pancreas cancer, but 99% specificity, which means it detects 1 false positive per 100, and you apply that to the general population with a 15 per 100,000 incidence, you're going to detect all the 15 cases of pancreas cancer because it's 100% sensitive, but you also find 1,000 false positives, even with that 99% specificity. So it's not feasible to screen the general population, again, within the constraints of the healthcare system in the United States. So we have to enrich. Again, I keep coming back to that word. It really is a theme in my talk, enrichment. So now, let's say we refocus these efforts, not in the general population, but in a 10-fold higher risk population, where you now have an incidence rate of 150 instead of 15 per 100,000, the same biomarker, now you apply it in this enriched population. Again, you'll pick up all the cases, but now you'll only have 100 false positives, not 1,000. So it's much more practical in our setting to do surveillance for pancreatic cancer in defined high-risk cohorts than to just go out and screen everyone. And again, I want to emphasize, this is one slide I just want to show, because we talk a lot about sensitivity and specificity of biomarker tests, but the one value that I think is really even more important is the positive predictive value, which is when a test is positive, when is it really positive, okay? And that is entirely guided by the population prevalence in which that test is being applied. And the higher the population prevalence, I talked about 15 going to 150, the better is the PPV. So you really want to be having a population where the PPV is at least respectable numbers and not very, very low. And this has been shown in some of these ctDNA tests that have been done by Gardant and others. Again, the sensitivity and specificity of these tests vary, but what really matters is the PPV, and the higher the enrichment of the population, if you apply it in the general risk versus high risk versus symptomatic, these are patients who are coming in with a suspicion of cancer, those are the individuals where the PPV of the test is the highest. So again, that enrichment is a pivotal part of any early detection paradigm that you want to implement. So again, it's about the enrichment, and we published this DEF model years ago, but basically what it stands for is you define your at-risk population using some clinical variable, then you enrich using a facile, easy-to-implement biomarker. It can't be an endoscopy, for example, in the US, that requires you to come in and get a $20,000 procedure. It has to be an easy-to-implement test that can be done by a primary care physician, usually in an office setting. And then, in those individuals where there is a positive signal, a post-enrichment, that's where you go and find this early lesion. And in the context of pancreas cancer, those defined populations are familial pancreas cancer, pancreatic cysts, and adult new-onset diabetes. And I'll talk a little bit about all of them. So hereditary pancreatic cancer or familial pancreas cancer, about 10% of pancreatic cancers have a germline alteration, and Steve and others have done tremendous work on this over the years. This number goes up to about 20% in younger onset pancreas cancers, and most famous of these families is the family of President Jimmy Carter, who had 5 siblings and 1 parent who had pancreatic cancer. He did not have it, obviously. The second category is these mucinous cysts in the pancreas. And again, surgeons in the audience know this. These are picked up on imaging scans, which are not necessarily done for a pancreatic symptom. Somebody could be coming in with some vague abdominal pain or a gallstone or a kidney stone, and there's a cyst sitting in the pancreas. And these numbers are actually somewhat outdated. Nowadays, we do close to 40 million scans in the US. We do a lot of CT scans in the US for not very important reasons always. And there's a lot of people walking around with these silent cysts in the pancreas. So in fact, we wrote a review a few years ago where we called it a man-made epidemic. And it truly is. It's driven by us doing so many scans. And this is what it looks like under the microscope. So you have these cystic lesions called intraductal papillary mucinous neoplasms. It's a mouthful, IPMNs, that actually are bona fide precancers of pancreatic adenocarcinoma. And you can see them on imaging scans, and you can follow them over time. So this is a bona fide high-risk population. The good news is the vast majority will not progress. About 15% of pancreatic cancers each year arise in the backdrop of the cystic lesion. So just do the math, about 53,000 each year, so about 8,000 or so arise on the backdrop of these cystic lesions. But there are about 6 million people walking around with cysts, so the vast majority will never develop pancreas cancer. The key here is to identify within this high-risk population who is at the highest risk that merits further intervention. I want to talk about this very interesting observation that was first made by a colleague of mine who was then at Mayo Clinic and now is at MD Anderson, Suresh Chari, who was the first author of this paper, where he kept seeing patients with pancreatic cancer who told him that they had developed new-onset diabetes for the first time 6 months or a year before the diagnosis of pancreas cancer. And this is beautifully mapped data in the Mayo Clinic system where when Suresh went back, he found that individuals with pancreas cancer, their blood sugar levels started getting ARI about a couple of years before their diagnosis, and then some of them steadily developed frank diabetes. And we now know that this duration of new-onset diabetes is really important. And it's very important for me to emphasize that we're not talking about long-standing diabetes for 5, 10, 15 years. We're talking about new-onset diabetes that arises for the first time in an adult, and in particular, new-onset diabetes that is accompanied by weight loss or is not responding to other diabetes, interventions like, diet or medications. And so again, this risk of pancreas cancer being there is very high in the first 6 to 12 months, and then it drops sharply and becomes kind of the risk that you have with long-standing diabetes, which is almost the same as the general population. So again, really want to emphasize that the duration of diabetes matters. This is from a study that we did in a large population. And the reason for this is because the diabetes is not causing the pancreas cancer. The diabetes is a symptom of an occult or asymptomatic pancreas cancer that has yet not manifest clinically. So it's a paraneoplastic diabetes. And so if an individual develops new-onset diabetes for the first time, again, in most individuals, 99% of the time, it'll still be diabetes. I don't want you to think that anytime somebody develops diabetes, it's pancreas cancer. But in that 1% sliver, there is a silent pancreas cancer that's sitting there. So this has now been validated by many studies, both clinical retrospective studies as well as AI-based studies. Diabetes, new onset diabetes and pancreas cancers are in fact linked. And so coming back to this roadmap for what we call earlier detection, we talk about early detection of pancreas cancer as being very important, but even earlier detection is important. If we can diagnose this disease at a resectable stage, get it to our surgeons, have these patients undergo adjuvant therapy and sort of the MRD pipelines that Klaus talked about, we can truly change the trajectory of this disease. So now we talked about who are these high-risk individuals, the ones in whom you can do this enrichment, and that's patients with new-onset diabetes, family history, mucinous cystic lesions, and the how is the biomarkers that Klaus talked about. I'm not going to talk about them because that was his talk, but I just want to emphasize one thing about pancreas cancer, which is the ctDNA studies that have been done, they're not very sensitive, unfortunately, in early stage disease. The very early stage disease where you want to diagnose pancreas cancer is unfortunately a stage where these tests are not very sensitive. And you have to often use things like, believe it or not, CA19-9, which we all think is a really bad marker, but actually doesn't do too badly. And some of the data that Dr. Robbins presented on protein-based markers, they often do really well in earlier stage disease compared to the DNA-based markers. And so most of the time, you might have to do like a two-step assay where you first do a protein or an antibody-based marker, you enrich one step, and you do a second set of enrichment with a ctDNA-based assay. Now we come to the F word, finding. We talked about defining who's at high risk, the enrichment with a biomarker test like Dr. Pantel described, and now the F word, which is finding, and that is these imaging studies. So you have to develop imaging studies that can pick up these small lesions, and this is where there's a lot of work going on in labs around the world. So I'm going to quickly now skip to this particular concept, which is defining who's at sporadic risk. So I talked about individuals with familial lesions. I talked about those with cystic lesions. But together, these high-risk categories still comprise only about 25% of pancreas cancers. Most pancreatic cancer patients are like the lung cancer patients who may not be smoking, and it's very challenging. They come off the street with a diagnosis of pancreas cancer, and you don't know what happened there? What was the risk factor? So the sporadic population is where there's a lot of activity going on trying to define who is at risk. And this is where I think AI can really help. This is a slide from Brian Wolpen at Dana-Farber. And in fact, there's a lot of activity going on right now, mining EHR, electronic health records, to find patterns that you may not think are important, but that may be contributing to an algorithm that can identify who is at risk for pancreas cancer. And again, we wrote this little one-pager in Lancet last year on how AI can be used to enrich for individuals, sporadic individuals who are at risk, who don't have an obvious attributable cause, like a family history or a cystic lesion. You're welcome to read it. It's very short. And then my last couple of slides is, surveillance for pancreas cancer still happens to be mainly passive. And we heard about this in the other talks as well. Somebody comes in who's at high risk, you do an imaging study, you tell them to go home and come back in a year or 2 years or 6 months or whatever, but you don't really do anything in the middle. Like, you're not doing anything actively to mitigate the risk of developing cancer. And this is where, we have examples like this individual who had so many cysts in their pancreas. I mean, kind of like Yoshi talked about his own story. And they have mutations you can pick up in the juice, in the duodenal juice. So you know there's something going on. This is a ticking time bomb, but there's not anything that's done except imaging studies. And so this is where the concept of cancer interception comes in. This was a review written by Nobel laureate Elizabeth Blackburn that used literally the football analogy of interception. American football, please, not European football, which we call soccer, but American football. And we have written a nice review on how this paradigm can apply to pancreas cancer. I'll just briefly say, and this is the part about the revolution, because the topic of this seminar is resignation to revolution. So we now have an opportunity to intercept pancreas cancer for the first time, potentially with vaccines and other approaches. the first such study of a KRAS-targeted vaccine in high-risk individuals. This is not somebody who had pancreas cancer. This is somebody who's at risk for pancreas cancer, was completed 20-patient proof-of-concept trial, but this has now opened the door for mRNA vaccines, peptide vaccines, and most excitingly, for the first time, as Rahul talked about, we have orally bioavailable KRAS inhibitors, a pill that you can pop that is relatively well tolerated by patients. Can we use them in a high-risk setting rather than a therapeutic setting for interception? So this is, to me, the revolution that's coming. And with that, I'm going to end my talk. Sorry to go over a little bit.
Thank you very much. Thank you very much. And during lunch, we'll have a demonstration of American football, just to make sure we understand what's going on. Thank you very much. Just before lunch, we have time for a couple of questions in the audience. We have an arm raised over here. Yes.
Yeah, Pascal Mann from Paris. Two remarks. Thank you very much for your talk. First, when you survey patient relative at risk, I do that since 25 years, you don't find a lot of cancer. Okay, it's very low prevalence, incidence. And I think it's very important to take into account the reduction of risk factor. When I see this relative, I probably save more life by saying stop smoking, make sport, and eat correctly. And the second, no, it's okay. I'm short.
Did you need me to say something?
Yeah.
Yeah. I mean, the comment is, yeah, sure. I mean, absolutely. You want to do all the good stuff. You know, don't smoke, no alcohol. In fact, you know, we just heard from our IR colleagues about the risk of alcohol intake and pancreas cancer. About 25% is smoking related, obesity. That's all great. But ultimately, you know, the majority of patients still don't have a single attributable risk factor, except the ones who have cystic lesions or a family history. And even in the ones with a family history or a germline mutation, the event rate is not very high. It is very variable between, you know, mutations. For example, patients who have a BRCA mutation, the lifetime risk, if they don't have a family history, is not very high. But if they have a family history, then it gets to the point where you can start doing surveillance. So again, I mean, Steve and all have done wonderful work on this. The surveillance is not uniform, and it varies depending on other parameters, the specific mutation, the family history, etc. So a lot of things go into the decision making of who to surveil and how often to surveil them.
Okay, great. Question here.
I enjoyed both of those talks a lot, and I agree with, I was going to just emphasize what Anirban just said about the event rate is so low, we really have to be careful when we're talking about screening beyond the highly enriched groups. But I was going to ask Klaus, in your guide assays, are you including the tumor-informed techniques, which we think are probably really the most useful in the MRD world? You mentioned the guide assays. Are those multiple different tests, not just one test, right?
No. We are actually now benchmarking around 20 different commercial tests. Most of them are tumor-informed, absolutely. And then we will pick probably 5 or 6 for the clinical validation studies. So, yes, I think in the MRD setting, there is a great belief that the tumor-informed assays have a sufficient sensitivity to pick up very small signals. The only, I think, challenge here is that, for example, in lung cancer, sometimes the biopsies, like in 20% of the cases, are not of good enough quality for whole genome sequencing. And that's becoming more or less the standard now. Huh? When we wrote the grant, it was whole exome. Now everybody wants to do whole genome. And here we see some real-world limitations, you know.
I think the American has, the Natera test is the most popular tumor-informed one that's in the U.S., I think. I mean, Anirban probably knows more.
It is. Natera.
Okay, great. We have a question here in the middle. Maybe time for 1 or 2 questions. Question here in the middle.
We won't eat anything anyway, huh? No.
Anthony Turpin from Lille. Thank you both for your excellent presentation. Dr. Mehitra, you have shown 22 million of CT scans performed each year in USA. Wow.
That's only for abdominal imaging. It's actually
Yes.
more than 100 million overall.
100 million overall.
We do too many CT scans.
Yes,
It's
that's the question. We have some paper related to the rising of the incidence of some cancer due to CT scan. What do you think about that?
Yeah, I mean, that's a real concern. I mean, there's been the study that was in JAMA Oncology or Internal Medicine, I forget, recently showing that, there is about 10 to 15% of annual incidence of cancers, especially leukemias, for example, or colorectal cancers, could be attributable to radiation risk from the CT scan. It's a real risk, and it's a controversial issue. But the fact of the matter is, we do a lot of CT scans in the US, and that's why we are also picking up these incidental pancreatic cysts, most of which will never progress to cancer. In fact, there is this whole term that we teach medical students called incidentalomas, as you know, which is basically these incidental lesions we pick up.
Thank you very much. Don't worry, in Europe it's the same. We perform 2 CT scans.
Yeah.
Great, we have 1 minute left. One last question. Professor Raul, or on the top? One last question.
Is a comment more than a question. I started at NIH during the Human Genome Project.
Yes.
So I have been in genomics, for the last 40 years, in any type of DNAs and things like that. But lately, I have become doing a lot, more proteomics and more proteomics. And when I do the multi-omics, and I compare how good of a surrogate is a genomic marker versus a proteomic marker, there is no difference. There is an amazing difference. Yeah. The proteomic marker has a performance that is very far superior than the genomic markers, which has led me to think some of my own data in the past, right? Because I look as a surrogate. So I saw that you did present it, and if I am right with my picture that I took from your image, all of them were tumor microenvironment protein. They were all soluble growth factors that were not really part of the cell, intrinsic part of the cells that we are measuring in things. So the comment is for all of us, right, to start taking the idea that we did have, and we do have an amazing tool, and it's called genomics.
Yes.
But that we have become extremely genomic centered.
Yeah.
And that if we do not go, because the correlation between genomic and proteomics is just like proteomics has like 40% more of truth in anything you do. That's a comment.
Yeah, no, I agree with you. And again, I think, when I heard Nelson's talk this morning, none of the signatures are genomic signatures. They're all based on expression. You have to go to the business end of the cell to figure out what it's telling you, right? So.
But let me say one word. I fully agree with you, but maybe, what I've seen in the biomarker field, that it's almost like in fashion, the proteomics went down, now they're coming back, which is great. The ctDNA were so high, now we see some problems, so it will be... Why don't we combine also markers? That would be at least my wish before the lunch.
That's exactly what I said.
Yes. Fingers crossed. And a nice note to finish on. Thank you very much, Professor Pantel and Dr. Mitra. Thank you very much.